Access to affordable health care is a right of every citizen. Recently, the world observed the International Health Day, raising questions about the state of health facilities in developing countries. In Nigeria, a state is setting the pace in ensuring inclusive health policy through the Lagos State Health Insurance Scheme. Today on Sound Health, we are looking at how to achieve inclusive health care in the country. I'm Olasumbo Modupe. Welcome to the program. It's still Sound Health on Lagos Television, and we are looking at how to achieve excellence in the health sector with special focus on the Lagos State Health Insurance Scheme. To do justice to that, I have with me the Honorable Commissioner for Health in Lagos State, Dr. Jide Idris. Welcome to the program, Doctor.
Thank you.
It's so good to have you on the show. The National Health Insurance Scheme Act Cap 42 states that every Nigerian has the right to affordable and inclusive health care. The reverse is the case, but the Lagos State government is coming up with a plan, the Lagos State Health Insurance Scheme. Why did we wait till now?
Yes, it's true. The scenario we've created is true, and it's a bit of an embarrassment to us here that we have to wait till now before we can get the acts together. The fact is that if you look at the National Health Scheme, basically we've been talking about health insurance in Nigeria for over 35 years, and our coverage is less than 6% or 7%. There are countries in West African sub-region and Africa who started after us. And so the problem again has to do with the institution that established this fact. Mind you, the National Insurance Decree came into being a couple of years back. One of the major problems with that is that, you see, the law does not make it mandatory, it is voluntary. And to me, any country, whether in the Western world or others, that wants a successful health insurance, it's always been mandatory. That's the only way you can ensure financial inclusion. Now, that's one. Two, I think it's the institutional governance structure of the National Health Scheme again that had a problem, because then rules were not strictly delineated. Where they delineated, they were not strictly enforced. The other issue was that is the fear of different state governments versus the federal government as to who contributes, who looks after the money. That was just there. So over the years, there has always been this agitation for state governments who are keen to establish their own insurance schemes. It took quite a while before it was finally accepted as the National Council on Health, which is the highest making policy body. So that was agreed to, and that's where all along to the state government, we created that insurance committee to look at this until we started having problems with what was happening at national level, and that's why we slowed it down. In the process again, we actually tried some pilot schemes in 4 local government areas under a community-based health insurance scheme to see it will work, how it will work, what challenge we're likely to face. So, and that's why, having done that, we know that it can work. And that's why the law was established in 2000, it was passed in 2015. It's not a perfect law, but at least it's the first step in the right direction. And ever since then, we tried to organize the implementation strategy. And mind you, this is very technical, and as a state government, we want to get it right, at least reasonably right, before we start. That's why it's taking this long.
Before now, the state government had in place the free health policy. Is a health insurance scheme going to replace this, and why was it repealed?
Well, the free health policy was established by past governments as a way of addressing that financial protection to the poor. We also do know that the free health policy did not work, did not achieve its aim. Nothing is free. One reason is that the budgetary provision to the health sector is totally inadequate. there is no way you can fund anything health free without the huge resources. If you trace the health budgets in any state government, even federal government over the years, you find it's totally inadequate. At the federal level, if you look at the health budget compared to the total national budget, it's less than 5%. Meanwhile, WHO, all of them are talking about 15% minimum. So let us assume that 15% is correct, 5%, 50%, that's not very, very little you can do. The same thing we have tracked in Lagos State for over the years now. Our budget for health has been increasing. But if you break down the budget to capital, recurrent, and personnel, you find that now you needed to take a decision in the do you make it free? You're going to make it free. Okay, you told people are free. They don't have where to go to. They don't have a proper hospital. They don't have anything. So which is the egg, which was the chicken? And so over the years again, we try to now to build up capacity, infrastructure at the health sector, because we made a conscious effort to increase the capital proportion of that budget. So the budget is totally inadequate. We have a huge population in the state to cater for. And so it stands to reason that we must look for other sources of funding the health sector. In any normal country, without a financing scheme, it's wasting its time. And that's why we feel that a health insurance scheme is essential. And now, people have been talking of universal health coverage. That universal health coverage means certain things. One, we must protect the poor. We must improve access. We must ensure quality of care. We must ensure comprehensive care. If you are going to do this, and the essence is that you have to de-emphasize free health. That's why we're going to this. So the health insurance to cater for all of this. So to answer your question, once this insurance starts, free health policy is needed because it's subsumed under that.
What makes the Lagos State health insurance scheme different from others? And what are the basics?
One, our law is mandatory for every resident of Lagos State. Every resident must contribute something because it's like creating a pool of funds that everybody is contributing. Again, ill health is a lot of probability. Today, God forbid, you might be ill. Tomorrow, it may be somebody else. But that person, if you're not contributing, what is happening is that people don't contribute. When ill health comes, they look at their pocket, they don't have enough money. That's what we're trying to avoid. So if you contribute little in the self-pause, at the point of ill health, you need to see a particular doctor or service. You don't need to bring out money again because you've been contributing. Or you go there, you show them your card, you go there, they will treat you based on what you are supposed to cover. That's one. Two, we said people who provide service, clinical care, we're not limited to public hospitals alone. We're including both public hospitals and private hospitals. And you know why? In this state, the private sector still cater for over 55%, 60% of the population. So it's an avenue that we've not really tapped. And if you want to improve access, we need to let them have a play. What this insurance scheme is all about is that the private sector will play. Now the insurance scheme thing and the contribution will guarantee payment for their services. At least reasonable for their services. So in effect, you have more providers who are providing services at different levels of care. So people don't need to walk too far to gain access to care. That's one. Two, our own is compulsory by law because there must be equity, there must be fairness. For those people who are very, very poor, the state government will cater for them based on what the provision of the law says. So those are the basic key things in our own law. Now, we have a benefits package and we have 3 schemes, but what we are starting with the basic scheme. In the sense that if you can successfully do this, we're going to take care of over 75% of the problems we have that can be treatable at the primary care level. And by this law again, we are trying to introduce sanity into the system. If you register, you can only access the health scheme through your primary care provider. In which case, are people who subscribe have a choice. You can decide to go to a primary care provider that is empaneled, or you go to a public facility. It's your choice. And because you are prepaying, you are paying something, If you are not happy, you are not satisfied, you seek redress. Those are one of the few things. And the services that are covered are those services that are common problems we have, that the problems that can easily be dealt with at the primary care level. Where they cannot do that, then they refer to the next level of care. So as a subscriber, as an enrollee, you can only access the scheme through a primary care provider. If it feels now that what you have requires the attendance of a higher level, then they will refer you.
Okay, looking at Lagos State, the cosmopolitan nature, we have diverse culture, diverse people. How do you intend to incorporate all these people? Because we have over 16 million, about 21 million people in Lagos State. How do you intend to incorporate everybody?
What the law says, the law does not differentiate whether you are Yoruba or Hausa. If you are resident in Lagos, it is compulsory for you that you must register in this scheme.
What about the database and all that?
So that's part of it again. You see, when we started the preparation, part of the thing that's actually making it long for us to implement now is the IT platform. When we first started, we did the actuarial studies. You needed to do a study that's done by experts to give us an idea of how much it will cost us to implement this scheme, how much people have to pay. When they came, and again, one of the problems again in this country is that data is not readily available. So even from what they gave to us, they recommended 70,000 naira per family of 6. But we presented all this and we gave government 3 scenarios: 70,000 naira, 50,000 naira, 40,000 naira. Because it's a new thing, because of the context of the poor people, the government chose 40,000 to start with.
For a family of 6.
40,000 naira for a family of 6. That is the father, mother, and 4 children.
Okay.
Now, that's the figure that group. Now, if they have more than 6, there are provisions for individual subscription, but those are going to be slightly higher because now the risk now is not being shared. You understand me? And that one again now, what we're trying to make it very easy for people to pay. So there are going to be different platforms. We're exploring the different platforms, whether people use cards, people use POS, people use scratch cards, people use bank cards, all those. We're exploring those people, we're talking with people so that we make it easier for people to pay. But you must contribute before you.
Are HMOs and other private hospitals, will they be involved, or is it just a public hospital affair?
No, I told you that this one is both for both public and private facilities.
Okay.
And the reason being that we need to increase access, or people must have increased access to care. Now, but again, as a provider, whether public or private, there are standard requirements because, like I said, one of the essence is to ensure quality of care. So, any provider who is going to be empaneled on this scheme is going to scale 2 levels of requirements. One, the provider must be accredited by a HEFAMA, that is a Health Facility Monitoring and Accreditation Agency. And for them to be accredited, they have to fulfill certain criteria, which they will inspect, which they will check. The essence is that we want to be sure that the facilities have the wherewithal to provide the services, quality services expected in terms of staff, in terms of equipment, in terms of so many cleanliness, provision of drugs, etc. That's all. Once they scale that, the farmer tells the agency that, okay, this facility A has satisfied us, it can be empaneled. Now the next set of requirements will be set aside. Based on that now is what they use now to check whether they... And one of those is also to ensure quality of care. The people who work in that facility must be indemnified. They must be insured for malpractice. Because now people are paying from their pocket, they have every reason to ensure that they get service for this. In terms of quality, we said every key personnel in that place must be BLS, as a basic life support certified. That's if you have an emergency, you can restore life, you can maintain life quickly. People must be trained. That is what happens all over the city. That's part of it. Each facility must have a BVN number because we're going to pay the facility. We want people to track the payment. We want to ensure that, so that some of those things we are putting now again for them to now, okay, you now be empowered. Now, right now, a farmer is being upgraded or reviewed services. part of the functions of the farmer is going to be outsourced to the private people who have the time and wherewithal to carry out the service. So that's the inspection, accreditation, they will do that. We are also building an online platform. People don't necessarily have to be coming to queue here to bring forms and fill forms. Once that platform is okay, they can fill their forms online, application online, we assess it before they go. So all those things we're trying to do. And again, of course, we are beefing so that the farmer itself will be in a position now to monitor properly. Then they have an IT platform. We are doing GIS mapping of all the facilities so that we know which area of Lagos is underserved, which area is overstaffed. So you understand, we know how to distribute this so that people, there must be equity, fairness, people can have easy access to this. So those are some of the things we are doing. So so the two levels to ensure quality of care.
We've had cases whereby a patient is turned down at a facility just because they tell you your plan does not cover this particular health care you're seeking. How do you intend to manage this with the 40,000 naira in place?
That is why we said at the primary care level, there are specific services that people are entitled to. Luckily, they are simple and basic things, like antenatal care, like immunization, the common childhood diseases how they can treat, like malaria, TB. These are basic things. So basic laboratory services. Now, if they need services beyond that level, they will be referred to a particular level. For instance, now, if you have normal delivery, or somebody now requires cesarean section that can be carried out at the primary care level, the doctor refers that patient to the secondary care level because that person is covered. So they can do surgical, whatever it is at the secondary care level, it's called part of that thing. The essence is that, look, you want to know your limitation at the primary care level, you go to secondary care level, and people who are going to do that are people who are accredited, who are qualified to do those services.
The House Committee on Health at the national level, they're going to hold a public hearing on the National Health Insurance Scheme. What are your expectations?
No, we've got the letter. We are reviewing it. We are going to send a memo, we're going to present a memo, which way, to the House Committee on Health to give our views on the thing. As it is, it's not clear whether their new law is voluntary or mandatory. We want to find out how now, with our state health scheme, in relation to what they are providing, that a lot of gray areas they need to clarify. You understand? So we are making the presentation at that level of care. And of course, we like the idea that the national level, they're looking at it nationally. The essence is we need to provide this care, quality care to our people. How best to do it is what we need to iron out based on this.
Before now, Lagos State has always experienced migration, people from other parts of the country, the state, boundary communities seeking medical help. Yeah. How do you intend to manage this when the scheme kicks off?
That's why one of the reasons in our law, anybody who is a resident must possess a LASRA card, Lagos State Residence card. Okay. You don't necessarily have to be a Lagosian, but if you're a resident in Lagos, you must get that card. With that card now, you give you access to that. If you don't have that card, you won't access to health care. Or you can go to any hospital, if they charge you through their nose, that's your problem. Because we need to streamline this. There's a need to put order into the system, because that's our next level of reform in the health sector.
Okay, how soon is the scheme going to take off?
Well, the scheme will take off this year. I also do know that we've been shifting. The reasons are very clear. I told you we had a delay in actuarial studies. We had issues of data in this country, and without appropriate data, it can't come to a sensible figure. That's part of that delayed the thing. The other issue is some policy decisions need to be made. So there are certain basics that must be on ground. Now we feel that we have reasonably, apart from IT and the pharma thing, we need to start sensitization. It's one of the reasons why this is real. And sensitization, that we have mapped out different stakeholders. We have looked at them, what are their peculiarities, what are their needs. We are addressing them one by one. We've been meeting with some of them. We've met with the providers. We've met with the health insurance associations. We've even met with some informal sector people We're working with some agencies of government and Ministry of Wealth Creation to have access. We've met with the labor union. We are meeting different. We're going to meet with the geologists, the market men and women. We have different stakeholders. Now, I think the next 3 months now, we're using to face, because they need to understand fully what this whole scheme is all about, what role they're going to play, what is required of them, what benefits they stand to gain, and how they need to operate within that scheme. But it is very essential that everybody is on the same platform with us. So once we finish that, reasonable for that, I think by the end, we will start the whole process this year. We will start with a soft launch and then graduate from that. We don't expect everybody to go on the scheme immediately. It's going to be, as people get empowered, as people get enlightened, they will enroll.
Thank you so much, Doctor, for sharing the state government's plan on Lagos State Health Insurance Scheme with us.
My pleasure, but like I said earlier, we're still going to go around to different stakeholders to propagate this. People will need to understand fully what it requires, what the whole scheme is all about. That's the only way we can ensure they are buying.
That was Dr. Jide Idris, the Honorable Commissioner for Health, Lagos State, and we have been discussing how Lagosians will benefit from the affordable and good healthcare services through the Lagos State Health Insurance Scheme. Sound Health continues with trending and home essentials. Please stay with us.
Sickle cell disorder is a disorder that affects the hemoglobin. Hemoglobin is in the red blood cells. The red blood cells are so many that's why blood looks red, because you have other cells in the blood, but they are not as many as the red blood cells, so you have the blood looks red. And in those cells you have hemoglobin. The hemoglobin carries oxygen that we breathe in to other parts of the body, and that makes us function. Oxygen to our brains, and if you are running, oxygen to your muscles when you're running. And that's why if you're running fast, you find you have to breathe faster because you're taking more oxygen. And this oxygen, as you take the oxygen, is the hemoglobin that carries the oxygen around to different parts of the body. So the hemoglobin is very important. But in this case, when you have sickle cell disorder, the hemoglobin is different from what we call the usual hemoglobin. The usual hemoglobin in humans is called hemoglobin A. And there's a slight change. And when there's a slight change, you can get different type of, there are over 1,000 hemoglobins that have been described. And one of the most common of the unusual ones is called hemoglobin S. And that is found in these tropical areas, especially where you have malaria, because those who inherit the S hemoglobin from a parent seem to do better with malaria than those without it. And that's why in these malarious areas you have people with AS who are becoming large. About 1/4 of our population have this AS. And where you have many people with AS, some people with AS would marry other people with AS, and some children will be born with SS, taking S from the father, S from the mother. Now, those who are born with SS will then have sickle cell disorder because they will not be so well. They have so many complications and they could die young from those complications. And even when they don't die, they could have a lot of problems like severe pains they could have. And that's sickle cell. So on average, they won't live as long as people who have hemoglobin AA or AS. People found that those with high fetal hemoglobin called hemoglobin F usually did better than the majority who didn't have that advantage. So people were looking for drugs that could make other people with sickle cell have a high F or fetal hemoglobin. And some of those drugs they were too dangerous until they found hydroxyurea would increase your F and be beneficial, and that's why it's being used. So that fetal hemoglobin is measured usually at the start before you start giving the hydroxyurea. You could measure it as you go along, and with it, you give the hydroxyurea, you find that the patient hardly comes in for pain crisis. If you're having 6 crises per year, maybe he has 1. And the patient lives longer, happier, can concentrate more on his job or her job. So, and it's the only drug that does that amongst the other drugs we give for people in sickle cell. And this you could find from, so that's it really. That's why the drug is used. The hydroxyurea, once we found that it was useful from the research in America, trying to introduce it here, only few people could afford it because the drug was very expensive. So I had to talk to my friend who ran Bond Ventures. They make drugs locally. I said, see whether you can get this drug cheaper, and he was able to bring it from India and produce it here. And they started calling their own oxyurea, their own brand.
Hope you enjoyed this week's edition of Sound Health. For comments and inquiries, please send SMS on 0818-815-3695 or follow us on social media at LTV Social, #Sound Health. A sound health is a sound mind. Make healthy living your choice.